and mental illness today, which has been one of our rotating talks. As I begin this presentation, no disclosures to report. And so what are we going to focus on, right? And I want to make sure we leave plenty of time for the case, which is really at the heart of the ECHO program, right? Sort of this co-management of de-identified cases, case discussions. So I really want to sort of leave sufficient time for that. And so we're going to try to cover in the next 20 minutes or so. I'm really going to start with what's something that all of us as clinicians face, right? Routinely, which is how do you differentiate between a substance-induced psychiatric illness versus an independent primary psychiatric illness, right? That's in assessment. That's often the first challenge we encounter. We're of course going to learn about the comorbidity between substance use disorders and various psychiatric illnesses. In fact, I'll start with that today. And then we're just going to start to construct a treatment approach for patients with dual diagnoses, which is a term often used to describe patients who have a psychiatric illness and a substance use disorder occurring concurrently with opioid use disorders, right? I've also included some slides in here that I won't go through in detail, but will hopefully be there for reference as points of thought. And you'll see when you encounter patients and you're going, what could this be? Could this be substance induced? Could this be a primary psychiatric illness? There are many different ways that it can present. So I've got some reference slides in here as well that of course will be available to all of you. So we'll start with just some definitions, some epidemiology. So this is a study from SAMHSA. I've used the 2016 data. I've seen the data from 2017 and 2018, from the National Survey of Drug Use and Health, which is NSDUH. And it's remained remarkably similar, right? So this is looking at past year diagnosis among adults age 18 and older, number in millions. So the red circle is everyone who had a mental illness in the past year. This yellow circle are all the individuals in the United States age 18 and over who met criteria for a substance use disorder in the past year. And this orange, of course, in this Venn diagram is the overlap. So I'm focusing here for a second here on this yellow circle. All the people in the US age 18 and over who had any substance use disorder in the past year, well, it's about 19 million individuals. But out of those 19 million, just over 8 million also met criteria, right, for another mental illness in the past year, which is roughly 40%. So the take-home point really is that substance use disorders do not happen in isolation. Very often, there are other mental illnesses present, there are other psychiatric conditions present that we must evaluate and address, right, to really help our patients. I can tell you that, and this may ring true for many of you guys, clinicians out there, that at our clinic, at the University of New Mexico's Addictions and Substance Abuse program, this number is far higher than 40%, right? Majority of our patients, in fact, have concurrent mental illnesses in addition to the substance use disorders. But the national data shows a prevalence of at least 40% or so, right? Now, this one is looking at a past year substance use disorder and a serious mental illness, right? And there again, you see that, out of about the 19 million people with a substance use disorder, about 2.5 million individuals, right, had a serious mental illness also present in the past year. So again, we gotta keep our antenna up and be mindful that this could very well be present. So these are just some other major national epidemiological studies, right? Essentially, and this is the summary, showing that having any SUD, which is an abbreviation for a substance use disorder, increases the odds ratio for another Axis 1 diagnosis. And this is before DSM-5, right? So if someone has a substance use disorder, they're more likely to have another psychiatric illness. If someone has a psychiatric illness, they're more likely to have a substance use disorder. That's what this second bullet is saying. And having a substance use disorder increases the likelihood for having another substance use disorder. So you can see that all of these things go hand in hand. And that's really the take-home point as far as epidemiology, that things don't happen in isolation. We must, keep our minds open and see what else could be going on so we can treat our patients to the best of our abilities. Some other data, right? Again, showing that if someone has a substance use disorder, right, they're maybe even up to 4.5 times likely to have a comorbid psychiatric illnesses, and vice versa. The relationship is sort of bidirectional. So if someone has another psychiatric disorder, they may be even up to 4.5 times more likely to have a substance use disorder. And some of the most sort of prevalent psychiatric illnesses we see in individuals with substance use disorders include affective disorders, so things like bipolar and depression, anxiety disorders, as well as schizophrenia. And this was a big study published in 2016, right? Looking at over 400,000 individuals from a national registry of psychiatric illnesses, which are often found in Scandinavian countries, right? And they found that if for patients, for example, who had a diagnosis of schizophrenia, the prevalence of any lifetime substance use disorder was 37%. So you can see just how prevalent substance use disorders are in various psychiatric illnesses. The most common substance use disorder was actually, perhaps unsurprisingly, alcohol use disorder, right? And patients who had substance use disorders were more often men, had fewer years of formal education, more often received disability pension, and also they tended to be more likely to die due to unnatural causes, right? Things like suicides, things like accidents, overdoses. So it clearly impacted even their kind of lifespan. So it is significant, right? And concurrent disorders are important. In addition to the lifespan, it's been shown, and again, this is from the paper from another paper from 2016, showing that when patients have dual diagnosis, that's what this DD stands for, co-occurring substance use disorders and other psychiatric illnesses, compared to someone who just has a serious mental illness or just a substance use disorders. When people have these things co-occurring, they're more likely, it's associated with more psychiatric hospitalizations, higher psychiatric relapses, increased number of suicide attempts, more violent behavior, more criminal behavior, more imprisonment, more family dynamic problems, loss of social status, poorer quality of life, greater medical comorbidity, more likelihood of HIV infection, higher rates of unemployment, homelessness, poor treatment adherence, and therapeutic failure, right? So hopefully this, drives home the point that we should care, because it impacts the lives of our patients as well as those around them when someone has both of these co-occurring. So that brings me to assessment. Just going to quickly glance at the time. We're doing okay, right? So the first point I want to make is, if you're seeing someone who's actively intoxicated, which I know those of you trainees or other physicians, other providers who work at ASAP, this happens all the time, right? Where a patient comes in, they're actively intoxicated, right? I think the first thing that I want to do is safety. Safety, for example, in terms of withdrawals or overdose risk, which I want to make sure, and that's why I think we want to be reviewing vital signs, right? Medical symptoms, any withdrawal management, which might be necessary. And the other thing really I'm going to focus on in terms of safety is suicidality and homicidality. Those are going to be my priorities. How do I keep these patients safe? How do I keep them from having an overdose event? How do I keep them from going into withdrawals that might be medically dangerous? And how do I keep them psychiatrically safe, right? Feeling safe emotionally. And then I'm not going to continue with a probing psychiatric evaluation in an intoxicated patient. I'm going to wait until sober. That's generally a good rule of thumb, right? So I wanted to really include that slide. Then once someone is no longer intoxicated, or I would add to that actively withdrawing, the big important part of assessment is determining whether an illness is independent, primary psychiatric illness, or substance-induced, right? That's our big goal. Substance-induced psychiatric illnesses are disorders related to the use of psychoactive substances and typically resolve with sustained abstinence. So often once we get them into some kind of a remission from their substance use, we would expect the symptoms of substance-induced psychiatric illnesses to improve. We don't necessarily have to provide treatment. However, if that co-occurring psychiatric illness is independent, the symptoms and the dysfunction, right, the impact on the functioning is going to persist even during remission, even during abstinence. And we're going to need to treat. Then there is this note, there's no specific period of time used to differentiate these disorders, and I'll get to that in a couple of slides to clarify that, right? So again, substance-induced disorders, the goals are going to be sustained abstinence or even reductions in use, reevaluating, and oftentimes we would expect these to improve. But with independent disorders, really all the data suggests and supports this idea that cessation of substance use is important, but by itself not sufficient. We're going to need to treat co-occurring psychiatric symptoms. We're going to need to provide treatment for those psychiatric symptoms to really improve outcomes. So how do we make this distinction, right? So I think in the patient's history, right, history taking is critical. There are three things I look for. One is the family history. Very often that can help us distinguish. I'll give you an example. We had a patient, I use this example because the patient had a history of heavy methamphetamine use and psychotic symptoms. And for a long time, we had no idea what was going on because patient wasn't able to go into any remission. And then we got some family history and actually found out that there is a strong history of schizophrenia on the patient's mother's side of the family. And so we sort of changed our working diagnosis to say the patient has methamphetamine addiction and schizophrenia. And we provided more aggressive treatment for the psychosis. And in fact, the patient did better. The other thing I ask for is the initial symptom onset. When did the symptoms first start, right? I have patients who say, you know, I did well until I was 14 or 15. I started drinking. I started using cannabis heavily. And that's when my problems came in. And on the other hand, I have patients who say, I didn't even drink until I was 17, but I remember being 6 years old and I would be afraid to go to school in the morning because I was so anxious. I would wake up with a stomachache. And maybe I even turned to drinking because it helped ease my anxiety, right? You see how different those two presentations are. And the third thing I ask is symptoms during periods of abstinence. I ask them, well, if many of our patients have periods where they were not using. What were things like? And I have patients who say things were great. I was able to get my GED or get my college degree or complete my probation. And on the other hand, I have patients who say when I was not using, I was a wreck. I would check my door handle 4 times before I would go to sleep. I was always feeling vigilant, right? And you can see that that can help us distinguish. So I would look at those 3 things in the history. And the next thing is observe what happens as you treat. Are the patients saying that my depression or anxiety are getting better? Once you got them stabilized on buprenorphine and they're no longer going through these cycles of intoxication and withdrawal, in that case, great. But if those symptoms are persisting, you want to start treating. This is just a more detailed slide for reference that gives you an idea about distinguishing between primary mental disorder versus substance-induced disorder. I won't go into every line here, but it's there for reference. Some more slides for reference here include, right? And I've gone by substance because often in practice, it can be a little bit more, it can be a little bit more sort of difficult to distinguish whether this is because of the substance use or not. So let's use the example of alcohol, for example, right? Alcohol intoxication, you can see things like mood lability, inappropriate or aggressive behavior, impaired judgment, impaired attention, impaired functioning. Well, those things could be due to alcohol intoxication, or they could be due to an underlying depression or bipolar spectrum disorder, right? So those don't necessarily help us, but there are things you see with alcohol intoxication that you wouldn't see with bipolar or major depression, including slurred speech, incoordination, unsteady gait, nystagmus, impaired memory, stupor, or coma. So that can really help us distinguish. Similarly, with alcohol withdrawal, you might see anxiety, insomnia, agitation, auditory hallucinations. By itself, that doesn't tell us if it's alcohol withdrawals or a psychiatric illness, but there are things you see with alcohol withdrawals, such as autonomic hyperreactivity, right? Tremor, nausea or vomiting, visual or tactile hallucinations, seizures or delirium, which would really clue us in that this is not necessarily a manifestation of a psychiatric illness, but I would really think about a substance-induced or a medically related cause. So similarly, we've included slides about cocaine, cannabis, opioids, nicotine for reference. So last in another 3-4 minutes, I want to go into treatment considerations. How do we make this plan? And this is courtesy of Dr. Paul Romo, who's one of our colleagues. You know, this is an example he uses for when he treats our residents, and I really like it. Right? He gives this example of having a ship that has 2 holes, and if we really want to keep the ship from sinking, you really gotta fix both of those holes at the same time. If you just fix one or the other, it's not gonna be enough, and the ship's still going to sink. Right? So similarly, I think if we really want to help someone with dual diagnosis or co-occurring mental illness and a substance use disorder, optimally, we must treat both, and we must treat both concurrently in an integrated manner. I said I'll come back to that little bullet, and this is what it means. That previously there was this idea where people would say, you know, we can't really diagnose a mental illness until you've been sober for 6 months, right? But it didn't really help people, because if they had, for example, PTSD and opioid use disorder, if you're not diagnosing and treating the PTSD, their opioid use disorder was unlikely to improve by itself. So eventually people started doing in a common clinical practice 1 month of sobriety. But now really the guidance from, from many professional organizations is that as soon as we know that someone has dual diagnosis, concurrent illnesses, we've got to start treating both simultaneously and not in sequence. And that's really what improves the outcome. So as soon as I know that my patient with opioid use disorder also has post-traumatic stress disorder, right? To use that example I used earlier, I am going to ensure that my treatment plan includes treatment for both and in an integrated kind of interdisciplinary manner, because that's what's really gonna improve the outcomes. And this comes from an article by Dr. Shuckett from the New England Journal of Medicine in 2017. And remember, substance use does not equal substance use disorder, and you must assess whether diagnostic criteria for substance use disorders are met, right? This in practice, I get this because someone will show up in the psychiatric emergency services and their urine is positive, for cannabis, for example, or a stimulant, and we get a referral, we see the patient, we evaluate them, and maybe what you have is someone who uses occasionally, but doesn't really meet criteria for a substance use disorder. And it's not to say that that's not worthy of intervention. It certainly is. But maybe in that case, what they need is sort of a brief intervention, right? Which we talk about in our SBIRT talk that Dr. Maley does. So I think really for appropriate treatment matching, we got to make sure what really is going on. Some general steps to treatment. I think for many patients with substance use disorder, especially those who have less severe depression or anxiety, psychotherapy is a great first-line treatment. We have many evidence-based psychotherapies for various illnesses, right? For example, CBT or interpersonal therapy for depression, or prolonged exposure or cognitive processing therapy, right? For post-traumatic stress disorder, CBT for anxiety. Think about it. And if you have the resources, allow the patient to engage in that. For pharmacotherapy, again, you want to wait until they're, beyond just sober, right? You want to make sure they're not acutely intoxicated or withdrawing. That's really, I think, more accurately, I mean by that you don't want to start a medication while someone is acutely intoxicated or withdrawing. But once they're past that, if symptoms are persisting, especially if psychotherapy is not helping, then adding on a medication can be of a lot of benefit. It may also be the first line for many patients, especially for more severe symptoms, certainly for things like schizophrenia or bipolar affective disorder, right? We're gonna wanna add in appropriate pharmacotherapy. It's been shown, and this slide is courtesy of PCSS, depressive and anxiety symptoms are common at treatment entry in specialty substance use disorder treatment. But generally, as you get patients stabilized, those symptoms improve. But if they don't, be sure to treat them with psychotherapy, with our medications. Keep in mind that patients who are treated with medications for opioid use disorders or medication-assisted treatments respond to medications at rates that are similar to those who don't have opioid use disorders. Avoid addictive medications if possible. In general, I'm not going to rush to start benzodiazepines or stimulant, if I can really help the patient without using them. And of course, if those are used, monitor carefully. Again, another reference slide in terms of what medications might be used. In general, again, these are medications we would use even for someone who may not have a co-occurring substance use disorder, right? So for example, for depression, thinking about our selective serotonin reuptake inhibitors, venlafaxine, duloxetine, bupropion, right? A couple of things I want to draw attention to. One is avoiding the use of benzodiazepines if possible. Oftentimes with our patients with chronic opioid use disorder, as we've talked about in our other talks, rates of chronic pain are elevated. So if you got someone who has an opioid use disorder and depression or generalized anxiety disorder, for example, and chronic pain, I would think about bumping up our SNRI medications such as venlafaxine or duloxetine, right, over the SSRIs. And in fact, that was demonstrated by a multi-site study called the SCAMP trial, that for that patients with co-occurring chronic pain and major depression, using SNRIs as first line combined with pain self-management, in fact, improved outcomes in terms of depression, in terms of chronic pain, and in terms of global functioning, right? So think about that. And also for bipolar affective disorder, valproic acid, right? When there's co-occurring substance use disorders, primarily alcohol use disorder, tends to be more effective. There's some indication in literature as opposed to lithium, for example. So you may want to prioritize that, and that's why I've listed it, right? So another reference slide. So I end with maybe this call to action. So knowing that these things go hand in hand, knowing that these things worsen outcomes, knowing that the best way to improve outcomes is by treating two concurrently, we would hope that that's happening, right? But in fact, maybe not. So this is looking at people with co-occurring illnesses, right? In 2016, age 18 or older, over half still received no treatment. About 38% received treatment for mental health services only, about 3% for substance use treatment only, and only 7% actually received treatment for both mental health, other psychiatric illnesses, as well as substance use disorders. Only 7%. And when we look at serious mental illnesses, that number was a bit higher, but only at 12%. So still left a lot, right? A lot of room for improvement. So I think that's why this is an important topic. Maybe this is sort of just a call to action for all of us to be mindful of this, on the lookout for it, and know that if you see both together, think about treating both together in an integrated way. And that's really this idea that we want to treat it integratedly in a parallel manner, collaborate with patients, and that's really supported by SAMHSA. And integrated treatment is actually associated with lower costs and better outcomes, including reduced substance use, improved psychiatric symptoms and functioning, decreased hospitalization, increased housing stability, fewer arrests, and improved quality of life. So I'll end here.